I'm Marc Passman, Professor of Surgery, Section of Vascular Surgery and Endovascular Therapy at the University of Alabama in Birmingham, Alabama. And I'm going to be presenting today an update on evidence-based guidelines for management of venous thromboembolism. It's important to note that evidence-based guidelines provide an excellent framework for clinical decision-making and should form a foundation for good guidance in terms of management of venous thromboembolism. Venous thromboembolism is an important problem, and if you look at the United States statistics, about 2 million patients will present with deep vein thrombosis per year, of which 30 to 40% will develop pulmonary embolism if untreated, and the fatality from pulmonary embolism can be quite high, accounting for 60,000 or so deaths per year. For the U.S. Healthcare system, that accounts for well over $1 billion per year of annual expenditure. Traditional Virchow's triad discusses the three things that contribute to deep vein thrombosis. And this can include venous stasis from immobilization or extended illnesses, hypercoagulable stage, which can be acquired from malignancy or acute phase response from acute injury or illness, and or it can be hereditary or acquired. And finally, some sort of vascular injury, which can be from a prior deep vein thrombosis or can include traumatic extremity injury. When evaluating a patient for venous thromboembolism, it's important to perform a risk assessment. There are individual patient risk factors that are important to identify. Most importantly, advancing age, a prior history of thrombotic events, and or a family history for thrombotic events, as well as obesity, smoking, and hypercoagulable states. There's also situational risk factors which can amplify individual patient factors, and this includes periods of decreased mobility, surgery, acute illnesses, trauma, and associated medical problems that can be predispositions for venous thromboembolism, which are listed on the screen right. Within hospitalized patients, the risk of developing deep vein thrombosis is shown in this slide and can range anywhere from 10% to as high as 80% in some patient populations. The patient population groups that are especially at risk are those with major traumatic injury, spinal cord injured patients, critically ill patients. For patients who develop venous thromboembolism, whether it's deep vein thrombosis or pulmonary embolism, the mainstay standard care is full dose anticoagulation. And we'll review the evidence-based guidelines to highlight this standard therapy. However, there's also some additional interventions that should be considered in some patient populations with venous thromboembolism. And these include thrombolytic therapy, thrombectomy, and occasionally need for angioplasty stenting and vena cava filter. So for deep vein thrombosis, if you look at the natural history of untreated deep vein thrombosis, about 50% or so will develop PE and the resultant potential for fatality. Because of this, the initial treatment has remained anticoagulation, and this is the standard therapy. And if you can place patients with deep vein thrombosis on anticoagulation, you can significantly reduce the risk of PE to much lower levels, 1 to 2% of patients when adequately dosed. Current anticoagulants fall into several categories. They're the Glycosaminoglycans, and this includes unfractionated heparin, low molecular weight heparin, and fondaparinux. There are the synthetic anticoagulants, and these are the direct antithrombins, argatroban, lepirudin, bivalirudin, or some of the newer agents, Dabigatran and Rivaroxiban, and the traditional vitamin K antagonists, Warfarin. And we'll review each of these categories. For the glycosaminoglycans, this slide shows comparison of unfractionated heparin in the left column, low molecular weight heparin in the middle column, and fondaparinux on the right. A couple important things to note here is, first and foremost, the unfractionated heparin is a much larger molecule compared to the low molecular weight heparin and the fondaparinux. This has an effect in terms of the pharmacology and the action of having a wider scope of anticoagulant effect, not just affecting antithrombin 3, but also factor 2A and 10A levels. On the other hand, low molecular weight heparin and fondaparinux as a smaller molecule has very specific effects and are more directed to the 10A level with less spillover affecting other coagulation proteins. Because of the smaller molecule, there is a little better predictable bioavailability of the low molecular weight heparin and fondaparinux, which allow dosing based on weight compared to unfractionated heparin, which has to be titrated to PTT levels. It's also important to note that the propensity for heparin-induced thrombocytopenia hit is higher with the unfractionated heparin because of that larger molecule and can be as high as 5%, much lower with the low molecular weight heparin and fondaparinux categories. In terms of monitoring, unfractionated heparin is traditionally monitored with PTT, but low molecular weight heparin and fondaparinux have to be monitored, if needed, with anti-10A levels. Warfarin's been around for a long time. It has several advantages in that until recently it was the only oral anticoagulant available. It's quite effective, and there are antidotes that exist if you need to reverse it, vitamin K, fresh frozen plasma, and it has a long half-life. In the same regard, however, it does have some disadvantages, and the long half-life can be problematic for patients who develop some bleeding. Because of the complex dosing with warfarin, it's not immediately active. It takes a bit of loading and adjustment, and it has some significant drug and dietary interactions, which can make the dosing somewhat temperamental. It's also important to understand that it requires close monitoring, and if there is a medication change in a patient, they may need additional INR checks. Warfarin, when you initially start it, does have a paradoxical hypercoagulable effect. If you look at the effect on the vitamin K-dependent proteins, the initial effect is actually on protein C, protein S. And for those patients that have undiagnosed protein C and S deficiency, they can become paradoxically hypercoagulable before they have the anticoagulant effect. Because of this, it's important whenever you dose warfarin to have the patient protected with heparin or low molecular weight heparin or fondaparinux prior to achieving therapeutic dosing. And we'll look at the evidence-based recommendations shortly. And equally important is understanding the pregnancy category for warfarin as well. It is teratogenic, and patients who are planning pregnancy or are pregnant need to be taken off the warfarin immediately. Some of the newer agents, the direct thrombin inhibitors, are seen in this slide, comparing argatroban in the column on the left, lepirudin in the mid-column, and bivalirudin on the right. These are specifically useful in patients who have heparin-induced thrombocytopenia for whatever reason can't be on one of the glycosaminoglycans. The dosing can be somewhat complex, and that although some recommended dosings are listed here, I would just recommend consulting your pharmacy on the best dosing regime. They are monitored with PTT levels and can be adjusted accordingly. And there is some difference in half-life, and certainly based on effect on renal dysfunction, liver dysfunction, may favor one agent or over the other. And then the newest anticoagulants are some oral agents. Dabigatran and Rivaroxiban are currently FDA approved and available. Apixaban is still under test. And there have been several areas of study for these pharmacologic agents, including VTE prophylaxis, treatment of VTE, stroke prevention from patients with atrial fibrillation, and acute coronary syndrome. So if you look at Dabigatran, this was released by the FDA in 2010, and specifically it was indicated for use in patients with atrial fibrillation to prevent stroke. Shortly after its release, however, there were some noted issues with bleeding complications, and this led to the FDA to issue a post-market warning regarding Dabigatran. There's also some concern with Dabigatran in that patients who were previously on chronic anticoagulation with other agents and switched to this agent for non-atrial fibrillation type issues have been developing some clot, and it may be that initially, while there's some enthusiasm for using this medication, there may be some potential problems that are just being realized. If you look at Rivaroxiban, this was released shortly after Dabigatran, and it was released in July 2011. Initially a release for reduction of blood clot risk in patients undergoing orthopedic procedures. The FDA has since expanded its indications for use to include prevention of stroke in patients with arrhythmias, as well as treatment and reduction of recurrent deep vein thrombosis. Again, this agent's still new, and it may take some time to sort out its best utilization, but certainly it offers some excitement for those that need chronic anticoagulation with oral agents, and may represent another option other than warfarin in the near future. So referring to evidence-based guidelines, for venous thromboembolism, although there are several evidence-based guidelines out there, the American College of Chest Physicians is really the standard document. The most recent version is the 9th edition, published in Chest 2012. And in reviewing the recommendations for initial anticoagulant treatment in patients with documented deep vein thrombosis and pulmonary embolism, the initial recommendations highlight the need to be placed on one of the glycosaminoglycan agents at the usual dosing. And certainly, if it's the unfractionated heparin, it needs to be dosed accordingly with PTT monitoring. Now, while these evidence-based guidelines highlight the glycosaminoglycans, the newer agents have not yet been placed in the evidence-based guidelines, and I would expect in the newer version that comes out in the next few years, there probably will be some added recognition for some of the newer agents. Anyway, that said, there is important concept that if you suspect DVT and that suspicion is high, that you should initiate treatment initially, even while you're awaiting diagnostic tests. And then in terms of conversion to warfarin, you should again initiate the glycosaminoglycan agent as a precursor to warfarin, and then start your warfarin and overlap both therapies for at least 5 days until the INR is therapeutic. And then once therapeutic, you can stop the glycosaminoglycan agent and then just continue with the concomitant warfarin. So for patients who have deep vein thrombosis, it's important to differentiate whether or not that DVT was provoked or unprovoked, because it may represent a different population. A provoked patient would be someone with a transient risk factor, something that's reversible. An example would be someone who was otherwise fine, may have been hospitalized for a traumatic injury and all of a sudden developed a deep vein thrombosis. That reversible risk factor and situation may be what has driven the deep vein thrombosis. Certainly that patient may require additional risk factor assessment and evaluation for some underlying predisposition. But that said, if it's an isolated provoked deep vein thrombosis, in general, the recommendation is anticoagulation with warfarin for a 3-month duration. On the other hand, for patients who have unprovoked deep vein thrombosis, that would be someone who was out ambulatory, just minding their own business and developed a deep vein thrombosis. Those patients may, in fact, have an underlying predisposition for hypercoagulability, and they should be treated not just for 3 months, but at 3 months, the patient should be reevaluated for the risk-benefit ratio regarding long-term therapy, and that may include some additional hypercoagulable testing. If it's the first unprovoked deep vein thrombosis and there are no other risk factors, then in general, long-term therapy is encouraged. Certainly, if it's a second episode unprovoked deep vein thrombosis or VTE, then long-term treatment is strongly indicated. All these recommendations are strong recommendations, grade 1, and the level of support for it ranges from A to C. And then for anyone with a deep vein thrombosis, to help with their symptomatic swelling and potential for post-thrombotic syndrome, they should all be placed in compression stockings. So those are evidence-based guidelines for proximal deep vein thrombosis, and that's defined as deep vein thrombosis from the knee and higher. There are patients that will present with isolated calf vein thrombosis, and that may be a little bit different entity. First off, there is a little confusion out there in terms of the definition of calf vein thrombosis, and this depends on the source vein for the thrombosis. And that can sometimes be a little plantar vein, intramuscular vein like a gastrocnemius or soleus vein, or an infrapopliteal vein, usually the tibial vein. The axial veins, like the tibial veins, are likely the more dangerous calf vein thromboses. But that said, it's important to differentiate the type of the calf vein thrombosis that someone may have. The incidence may range from routine screening studies of hospitalized patient anywhere from 10 to 40% to those that present with some type of symptom, either leg symptom or pulmonary symptom, in which the incidence may range from up to 50% in some studies. So really a wide range of incidence reflecting some of the confusion in the definition of calf vein thrombosis. The problem with calf vein thrombosis is it does carry some risk of PE, again, ranging anywhere from 0 to as high as 6% in some studies. There is also the potential for propagation into a more proximal segment, or higher, and that can be as high as 15%. And then the potential for post-thrombotic syndrome afterwards also is a wide range. But in general, the more severe advanced disease, those that we would correspond with a clinical class 4 to 6, end-stage venous insufficiency, can be as high as 5%. The controversy with calf veins is highlighted in this particular article published in the Journal of Vascular Surgery 2012. And this was a meta-analysis looking at several papers out there. And of over 1,500 citations reviewed, they focused in on 31 relevant papers. But the long and short of their review was that calf vein thrombosis will have a risk of propagation, a potential for PE, and a potential for recurrence. So the option of doing nothing is considered unacceptable. That said, the option should either include surveillance, in other words, bringing the patient back in a few days for another ultrasound to make sure there's not propagation, or anticoagulation, and that should be dictated by the clinical scenario. Similarly, this meta-analysis, also published in the Journal of Vascular Surgery 2012, also highlighted the controversy with calf vein thrombosis, but came to essentially the same conclusion, in that the anticoagulation therapy with patients with calf vein thrombosis may in fact decrease the incidence of PE and thrombus propagation. And if you look at the data and the tables from that study, you can see the top table looked at the rates of PE, the middle table, the rates of thrombus propagation, and the bottom table, the mortality rates. And if you look at the odds ratio diagrams on the right, for all three categories, there was some favoring of anticoagulation over controls for patients with calf vein thrombosis. So bring this back to the evidence-based guidelines then. For patients who do have isolated calf vein thrombosis, I think it's important to differentiate, again, whether or not this is a true calf vein thrombosis in the tibial vein versus one of the muscular or plantar veins, because they do mean different things, the former group carrying a little bit more risk. But in general, the evidence-based guidelines state that patients with isolated distal deep vein thrombosis without severe symptoms or identifiable risk factors for extension, those are the patients that should have serial imaging over the next few weeks to make sure that there is no propagation, and that's favored over anticoagulation, although that recommendation is weak or a grade 2C recommendation. If on surveillance there's no propagation, then there should be no need for anticoagulation. On the other hand, if there is propagation, whether it's confined to the calf veins or higher into the more proximal veins, those patients should get anticoagulation. On the other hand, patients who have isolated calf vein thrombosis and present with severe symptoms, either leg symptoms or pulmonary symptoms, and or have risk factors for extension, those patients should receive anticoagulation as an initial therapy. So that's the standard of care evidence-based treatment for patients with deep vein thrombosis, both proximal and isolated calf vein. That said, there is a growing body of evidence to support more aggressive removal of clot in patients with deep vein thrombosis. The goals of these procedures are to reduce the acute symptoms and also potentially to reduce the risk of post-thrombotic syndrome in the future. If you can remove the clot early, you might be able to preserve some of the valve function in the leg veins. In general, the eligibility criteria for some of these advanced catheter-directed therapies include patients with extensive deep vein thrombosis, especially if it extends into the iliofemoral vein segment above the groin. If the clot's been there for less than 2 weeks, the more acute clot is easier to remove than the more chronic clot. If the patient has good performance status or ambulatory, if there's a low risk of bleeding and low risk for giving thrombolytic agents, and if the life expectancy is greater than a year. Based on these eligibility criteria, patients should be considered for advanced catheter-directed therapies. So if you look at some of the data supporting this notion, this is a National Venous Thrombolysis Registry from 1999. It's some earlier data, but really started pointing the evidence in this direction. Based on this registry, patients undergoing catheter-directed thrombolysis had complete or partial lysis in 84% of the cases. And if you look a little farther down the line, 1 year, 60% of these veins were still open. In the registry, there were some few systemic effects, some minor bleeding complications in 16%, need for transfusion 11%. But the potential for pulmonary embolism and or life-threatening bleeding, such as intracranial bleeding, was quite low. And then looking at the potential for post-thrombotic syndrome, comparing those treated with just anticoagulation alone versus those that received the catheter-directed therapy, there was data to suggest that the lysis improved the potential and prevented post-thrombotic syndrome. Based on a Cochrane review, a little more recent data updated in 2010, this looked at 12 randomized control trials that included over 700 participants. And again, across the board, they noted improved complete clot lysis, improved venous patency, less post-thrombotic problems, and improved venous function. However, there were some bleeding problems also noted. So based on the Cochrane review, in general, thrombolysis appeared to offer advantages of reduced post-thrombotic syndrome and maintaining venous patency after deep vein thrombosis over extended period of time. They emphasized that strict eligibility criteria needs to be adhered to improve the safety and effectiveness of this treatment. And that it's important to use optimal drug dose and delivery, although this has yet to be determined because of some of the bleeding effects. It's important to focus your treatment accordingly. So catheter-directed thrombolysis as a sole therapy, this is basically placing a catheter within the vein and clot and allowing the lytic agent to drip directly into the clot. As a sole therapy, the problem is that it does take some time, and because of the time, larger doses of lytics are required. And this may be, in fact, what leads to the bleeding risk over time. If you have to give more lytics, there's more potential for bleeding. And because of the concept that the sooner the clot is removed, the better potential there is for valve function. Because this takes a little longer, there may be the potential for non-recovery of some of the valve function. So with that in mind, there are some additional adjunctive techniques that allow clot removal a little more quickly. And because of this concept requires a multimodal approach, and whether it's just catheter-directed thrombolysis alone, or using some of the newer technology that allows mechanical clot removal or pharmacomechanical clot removal, that is mixture of lytic agents with some of the mechanical methods, as well as identifying underlying pathology, venous compressions and strictures, stenoses that might require venous stenting, as well as occasional use of filters. This should all be done under a multimodal approach. So looking at this concept of pharmacomechanical, again, combining lytic agents with mechanical catheters, this particular study from Journal of Vascular Surgery 2004 highlights a few key points. First, that in patients undergoing pharmacomechanical methods, there is almost 85% clinical symptomatic improvement, and 65% of patients had complete thrombus removal, and 35% had some degree of residual clot. And required some additional catheter-directed thrombolysis beyond the initial setting. Interestingly, about 61% of patients had some undefined lesion that led to the initial clot that required some additional treatment after that lesion was uncovered. The idea of using the pharmacomechanical techniques is important because it really facilitates the thrombus extraction that's concluded in the study. By decreasing the overall treatment time may lead to less bleeding issues and improved patient outcome. And this can translate into some additional advantages. This particular study, which was a follow-up of that study previously presented, does show a comparison of the yellow bars that show catheter-directed lytics alone versus the pharmacomechanical techniques in the blue bars. And effectiveness was essentially the same across the board. And then, more importantly, when you look at hospital cost, the pharmacomechanical techniques, because they are quicker, led to less hospital costs, about half, compared to the catheter-directed therapies alone. So to facilitate these pharmacomechanical options, there are several techniques that are available. This is one system out there, the Angiojet thrombectomy system. And this system is based on the Bernoulli-Venturi principle, in that the catheters that are used have a high infusion pressure that's generated at the end of the catheter in a reverse direction. And what this effectively does is it creates a vortex that allows suction of clot directly from the vessel. And then, depending on the size of vessels, there's different size catheters that can be used. With the pharmacomechanical technique, this device can also deliver the lytic agents right into the clot, allow the clot to marinate with the lytics for a short period of time, 20 to 30 minutes, and then facilitate the aspiration phase. And if you look at this particular case right here, this is a venogram showing iliofemoral deep vein thrombosis. And then after placing the Angiojet catheter and bathing the clot in the lytic agent for a short period of time, after 20, 30 minutes, you can already see the clot is beginning to clear. And then this slide shows the actual catheter being passed up and down through that vein, which facilitates a more complete clot removal and patency of the vein. So effectively, with a short period of time, all that clot was removed and patency of the vein was restored. Another device out there, the Trellis catheter, is a little bit different in that if you look at the diagram on the screen right, there are two balloons that are inflated within the vein that allow isolation of the clot and lytic agents. So effectively, between the balloons, the lytic is infused. That wire that runs between the balloons is then turned on by the oscillation drive unit. And essentially that wire will oscillate back and forth, mixing the lytic agent with the clot. And then after a short infusion period and mixing period, there's an aspiration port that allows the slurry to be removed between the veins, between the balloons. And effectively, in doing so, the balloons are isolating the clot, isolating the patient from the lytic agent, and allowing smaller doses of lytics to be used. And this shows another case, again, the two balloons of the device that are isolating the segment of clot, the lytic agent being infused and the oscillation occurring. And then after aspiration of the clot, there's actually was an underlying lesion that you can see in the middle slide that was treated with a stent. And then another device out there, this is the EKOS catheter. This is a catheter that allows lytic agents to be delivered into the clot. But what makes it unique is it uses ultrasound to force the lytic agent into the clot. And basically, when you place a sound wave within a medium like clot, you can effectively create cavitation of the fibrin bonds within the clot. And with those explosions of the bonds, the clot begins to open up to allow the lytic agents to seep into the clot and effectively allow the agent to work quicker and more effectively in a shorter period of time. The unit has various parameters that can be followed, but overall this does allow the lytic agent to be delivered quickly and the effect to be realized quickly. And what you hope for is this particular patient seen here. You can see before this patient that presented with iliofemoral deep vein thrombosis in the right leg, and the leg veins being all congested. You have that purplish discoloration, almost a phlegmasia ceruleus dolens compared to the other leg. And after the catheter-directed therapy, the leg is returned to normal coloration, the swelling's gone, the venous congestion is gone. And more importantly, you hope that the vein valve has been preserved. And if you look at the long-term outcomes of these catheter-directed therapy in terms of preserving venous function, this is the Caventi study, which was published in Lancet 2012. And what this study shows is that for patients undergoing catheter-directed therapy over standard anticoagulation treatment alone, there was an advantage in terms of prevention of post-thrombotic syndrome at 24 months. So this led the authors to conclude that catheter-directed therapy should be considered in patients with high proximal deep vein thrombosis and low risk of bleeding. So based on all the evidence out there regarding catheter-directed therapy strategies, recently the Society for Vascular Surgery put out this evidence-based guideline published in 2012. And what this shows is that for early thrombus removal, it should be considered in patients with initial episode of acute iliofemoral deep vein thrombosis, less than 14 days duration, patients who have a low risk of bleeding, who are ambulatory with good functional capacity and acceptable life expectancy. Early thrombus removal as a treatment choice is extended for patients, especially if they have limb-threatening venous ischemia in the iliofemoral deep veins segment. And that's independent of whether or not that extends down in the femoral popliteal segments. And those are the classic phlegmasia cerelia dolens type patients. Techniques for early thrombus removal, percutaneous catheter-based techniques are recommended as a first-line therapy in patients meeting those eligibility criteria. And pharmacomechanical techniques are recommended over catheter-directed therapy alone. Open surgical venous thrombectomy, that is making an incision and removing the clot directly, should be only an option in patients who can't, for whatever reason, undergo catheter-directed therapy. In terms of placing filters to prevent clot migration and PE during these procedures, in general, while filters used to be placed routinely, there is in fact a low risk of PE when you do these procedures. So because of that, most centers that do these procedures have eliminated the routine use of filters and are just using them in selected cases, specifically in patients who may have more potential for PE and or have limited cardiopulmonary reserve. For patients who have an underlying lesion that's uncovered after clot removal, those patients should be treated with a venous stent. And then for those patients that are candidates to undergo early thrombus removal, all those patients should then be treated with standard anticoagulation as per the evidence-based guidelines presented previously. And all patients should be placed in a compression stocking. So those are catheter-directed therapies. Let's cover vena cava filters a little more specifically in terms of the evidence-based guidelines. In general, absolute accepted indications for vena cava filter use are listed in the column on the left. And in general, these include patients who have documented deep vein thrombosis or pulmonary embolism, and for whatever reason have a contraindication to anticoagulation. Whether this is because they've developed some bleeding issue or have some other problem taking anticoagulation, and or patients who might develop recurrent thrombosis despite being on therapeutic anticoagulation. Those are all patients who should be considered for vena cava filter placement. On the other hand, there are some additional relative or controversial indications, and those are listed in the column on the right. And whether or not this includes a patient who has poor compliance with anticoagulation, or as I mentioned previously, those undergoing iliofemoral thrombolysis, or patients who may have chronic pulmonary hypertension and low reserve, those are all selected indications. Probably the biggest controversy exists in the last bullet point, and those are patients that undergo filter placement for prophylaxis. That is, a patient doesn't have documented deep vein thrombosis, but may be at high risk for whatever reason, being in the hospital or needing some major operation. This represents a controversial group in that there is unclear data to support either for or against filter use. We'll highlight that a little bit more shortly. So if you look at vena cava filters out there, there are several FDA-approved commercially available filters. Filters in general come in two categories. Those are permanent filters, defined as filters placed for permanent use and should extend the life of the patient. and optional filters, which also carry a permanent indication based on FDA approved indications for use, but have an option for retrieval. So looking at vena cava filter use, there is only one randomized multi-center trial published in New England Journal of Medicine in 1998. And the PREPIC study was basically a 2x2 factorial design, enrolled 400 patients. And by 2x2 design, it randomized half the patients to filters, the other half to no filters, and then randomized half the patients to unfractionated heparin, the other group to low molecular weight heparin, all of which were converted to Coumadin and treated for 3 months. But this study showed that within 12 days, within 2 weeks, there was a significant decrease in PE in those patients who required filter compared to no filter. However, at 2 years, there was an increased risk of either recurrent deep vein thrombosis or vena cava thrombosis in those patients who did have the filters placed. And if you look at the follow-up from the study, this was published in Circulation 2005 and represents the 8-year follow-up of patients in the original PREPIC study. Again, you see that trend extend out a bit farther. In terms of risk of PE, filters seem to offer some protection from PE. Looking at the graph on the right column, graph A. And then in terms of the potential for deep vein thrombosis later on, the middle graph, there was a higher incidence of that potential in patients with filters. However, in terms of survival probability, there was really no difference between filter and the no filter group. So this led the authors to conclude that really at the 8-year mark, vena cava filters offered a reduction of the risk of PE, but did have a problem with increased potential for deep vein thrombosis and no effect on survival. In terms of in-hospital patients, though, there is some growing evidence that there may be some benefit to filter use. This particular study published in the American Journal of Medicine 2012. And if you look at the table here, this shows comparison of patients with vena cava filters, the gray bar, versus no filter, the black bar, and categorizes patients based on hemodynamic stability and whether or not they required lytic. And while there was really no difference in the stable patient that did not receive lytic, there was some advantage to filters in patients that were stable and required lytic and or were unstable whether they received lytic or not. So this led the authors to conclude that it seemed prudent that vena cava filters placed in patients with documented PE were unstable and patients who may be stable but receiving lytic therapy. So that said, there is a problem with the use of permanent filters. And this particular slide outlines the outcomes of several commercially available FDA-approved permanent filters. And essentially, the problem is that it can be a low risk of recurrent PE. There can be a low potential for cable patency, but that varies based on filter type, as well as potential for migration and cable wall penetration. And if you look systemically at the use of retrievable filters, you see somewhat similar pattern. This is the frequency of PE in patients with retrievable filters. It really, they work quite well at preventing PE. However, there can be problems later on with deep vein thrombosis, filter migration, and vena cava thrombosis seen in each column there, both based on the filter type and the aggregate total at the bottom. So in this particular study, the authors concluded that in high-risk patients for whom anticoagulation was not feasible, retrievable filters was effective at preventing PE, but there were some long-term complications that raised serious concern regarding the use of these filters. So because of that, the American College of Chest Physicians, in terms of the evidence-based guidelines, really focused on the supported use of filters, and that is that for patients who have deep vein thrombosis, first and foremost, again, they should be treated with anticoagulation. Adding a filter to someone who can be anticoagulated does not offer any benefit. However, for patients who do have some problem with the anticoagulant therapy and cannot receive therapeutic anticoagulation for whatever reason because of risk of bleeding, Those are the patients that should absolutely receive a filter. And certainly when that risk of bleeding subsides, at that point in time, anticoagulation should be initiated. However, for patients that require filters for prophylaxis, there is recommendations in the opposite direction. And if you look at the recommendation for trauma patients, the American College of Chest Physicians guidelines actually recommend against the use of vena cava filter as a primary preventative measure. While this is a low-grade recommendation, it can be somewhat equivocal based on the data. What's also missing from the American College of Chest Physicians evidence-based guidelines is that there are no filter-specific recommendations for other high-risk groups, such as spinal cord injured patients, bariatric patients, surgical oncology, so on and so forth. What is clear, however, is high-risk individuals who do receive a filter, they should be treated with anticoagulation when the bleeding risk subsides. There are some challenges when looking at the data, and this is what makes it a low-grade recommendation. First and foremost, there are no randomized trials on the prophylactic use of vena cava filters in any patient population. There's really no direct evidence of efficacy. And based on the data, there's inability to predict which patients might benefit and which ones would not benefit from filter use. In short, the problem is the availability of filters should not expand the indications for filter use, but there still may be a sub-risk group that would benefit from prophylactic filter use. That said, this has caught the attention of the FDA, and in 2010, they issued this warning based on several complaints that they had received. Essentially, over the course of a short period of time regarding retrievable filters, there have been almost 1,000 adverse event reports, as you can see listed in the column on the left. Because of this, the FDA recommended that if you are going to place a retrievable filter, it is the responsibility of the person caring for that patient and or the person placing the filter to consider retrieval of that filter as soon as possible, either when protection for PE is no longer needed or when the patient can be started on proper therapeutic or prophylactic anticoagulation. In terms of retrieval of filters, there's also some variability in terms of timing. If you look at the indications for use respective to each individual filter type, there's a wide variety of maximum implantation time and acceptable IFU-based retrieval time. So regarding a vena cava filter placement specific to the retrievable category, there is some controversy also in terms of how long you can leave these filters in place. If you look at the timing of retrieval based on the indications for use, depending on the filter type used, there is a wide variety of recommended times. Part of this is based on data, part of it is based on what was approved for by the FDA. In reality, the retrievability of a filter is limited by several things. In part, it can be the clinical status of the patient. Has a lot of injuries, needs a lot of operations. There may still be need to leave the filter in place. Then technically speaking, if there is trapped emboli within the filter or the filter is too incorporated, technically it may be difficult, if not impossible, to remove. And then the biggest problem really in this group is patients who get lost to follow-up. And this is really what attracted the FDA's attention, is that a lot of these retrievable filters were being placed but not retrieved. So because of that, if you just leave filter retrieval up to the patient just kind of coming back and showing back up for the filter removal, that has a low yield rate and a large potential for loss to follow-up. On the other hand, if you look at active-based systems that are in place to identify patients who have filters in place and then to bring those patients back, that really can go a long way to improve retrievable window for these patients. So again, any facility or practitioner who's placing filters should have some responsibility and active measures in place to get those patients back and to remove those filters when appropriate. So in conclusion, to summarize the evidence-based guidelines out there for patients who have deep vein thrombosis, if it's involving the iliofemoral segment, those are the patients that you really need to consider advanced catheter clot removal. Whether it involves the iliofemoral or femoral popliteal level, all those patients should be anticoagulated. And based on the presence of provoked or unprovoked scenarios, that will dictate the duration and extent of anticoagulation. All patients should receive compression. For patients with isolated calf deep vein thrombosis, clearly more evidence is needed. But in general, those that have unprovoked DVT and or present with some sort of symptom, those should receive anticoagulation. On the other hand, those that have some sort of transient reversible risk factor may be asymptomatic, as found during routine screening, or are isolated just to the muscular vein segments. Patients that should likely undergo surveillance with follow-up ultrasound within a week or two to make sure there's not propagation, reserving additional anticoagulation treatment for those that do propagate. And again, these patients, like any patient with deep vein thrombosis, should receive graduated medical compression stockings. In terms of vena cava filters, clearly those patients who have a documented deep vein thrombosis and for whatever reason cannot be anticoagulated, that is the clear indication for vena cava filter use. And as soon as they can be anticoagulated, then the anticoagulation should be started at therapeutic levels. The prophylactic filter category is what remains controversial, and there needs to be extended evidence to support either use or not using these filters for prophylactic indications. That said, it is important to differentiate whether or not a permanent filter is needed, and certainly if it's permanent filter type indication, a permanent filter should be placed. On the other hand, if there's a transient risk profile or a transient need, that's really where the retrievable filters should be considered. And then if you place a retrievable filter, those filters need to be removed, ideally as soon as the patient can receive anticoagulation once bleeding risk subsides. And really that should be on the sooner end, and even sometimes before the patient leaves the hospital. So in conclusion, I would refer you again to the American College of Chest Physicians guidelines. You can find this online for free. It's an excellent resource. There's a lot more in this document than what was presented here. We just touched upon the key points and a little bit of the surface of the guidelines. There are some very specific guidelines within these for various scenarios, and again, I would encourage you to pull up the reference. But in general, for treatment of VTE, anticoagulation remains the standard therapy. Again, catheter-directed therapy should be considered in selected patients, with catheter-directed therapy preferred over operative thrombectomy. And certainly those pharmacomechanical techniques we discussed earlier are preferred over catheter thrombolysis alone. The vena cava filters need growing and careful attention. But all of this should be handled under a multimodal approach where the expertise and resources are available. And in terms of University of Alabama at Birmingham, we have our UAB Vein Program, and we cover really the comprehensive care for venous problems, whether the thrombotic issues or other vein problems. But within this multimodal approach, we can take care of the really sick patients on the acute care side, and then the patients who have more chronic issues we can see in our outpatient setting, the UAB Vein Clinic. But with this multimodal approach, we really can gear the therapy accordingly to the patient we're seeing, and really make some good clinical decisions using the evidence-based guidelines as framework, and then applying those appropriately to the particular patient and clinical settings. If you have a patient who requires evaluation for a vein problem, whether it's a thrombotic issue or some other venous disorder, if it's an acute care problem and requires inpatient consultation and or transfer, you can contact us through the UAB MIST line, 1-800-UAB-MIST. If it's a patient that has more chronic venous-related problems, we would be happy to see them at our UAB Vein Clinic with the contact information seen here. You can also visit our website at www.uabmedicine.org/vein. Thank you.